It is my pleasure to welcome you to Illinois Bone and Joint Institute's 6th Virtual Adult Education Series program with the North Suburban YMCA, entitled Neurology and Concussion Management, hosted by Dr. Anthony Savino. Dr. Savino is a board-certified neurologist with fellowship training in sports neurology. In addition to the treatment of all adult neurological disorders, he specializes in the management of mild traumatic brain injury and concussion, headache, sleep and mood problems, and maintenance of long-term brain health in athletes of any age. Dr. Savino's interests include management of acute concussion, autonomic dysfunction in concussion, treatment of post-concussion syndrome, and post-concussion headache. Dr. Savino is a neurological consultant for the Chicago Red Stars, Chicago's National Women's Soccer League franchise, the Chicago Wolves, and Lake Forest College, in addition to various local high schools and club teams. He also serves as a team pool physician for the U.S. ski and snowboard team. This evening, Dr. Savino will discuss overarching brain health with a focus on head injury and head injury evaluation. His philosophy of care is that treatment needs to be personalized for each patient. According to Dr. Savino, it is less about a protocol and more so a process. Dr. Savino will be addressing your questions at the end of his presentation tonight. Please keep your questions general, as he will not be able to address individual concerns without individual consultation. When you have questions for Dr. Savino, please type them into the question section on your screen, and I will receive them and relay them to him at the end of the program. If you submit a question, please know that we will do our best to answer it about 45 minutes or an hour from now. However, if it is too personal, I may not be able to include it for Dr. Savino to address. Thank you again for joining us this evening. We hope that you will learn a lot about brain health, mild traumatic brain injury, concussion and head injury, and evaluation from Dr. Savino. Thank you, Dr. Savino, and please take it from here.
Wow, well, thank you very much for that introduction. That was fantastic. Please let me know if you can hear me.
Yes, I can hear you, Dr. Savino.
Okay, good. And you can see my screen?
And I can see your screen.
Okay, great. Perfect. So thank you again for that introduction, and I'm happy to be here tonight. We'll kind of dive right into it, and it was mentioned we will go through questions. We'll have plenty of time for questions at the end, so please hold on to those or send them in as we go along so we don't forget them. I'm going to do it as comprehensive a job as I can covering the topic of head injuries and concussion. 45 to 60 minutes isn't long enough, but we'll touch on some important points. And again, if there's specific questions, we will address those. So the title of my talk tonight is Assessment of Head Injuries and Concussion Management. As was mentioned, I'm the program director for the Illinois Bone and Joint Sports Neurology Clinic. I have no relevant disclosures for this talk tonight. So as was mentioned before, again, I'm a sports neurologist. What does that mean? You probably have never heard that before. Basically, it means I'm a neurologist who is into sports. So just as we have orthopedic doctors and family care doctors, we have neurologists that are primarily involved with athletes, and got involved primarily to take care of the head injury population, brain injury population, but we also see other patients. So I treat all neurological injuries from playing sports, again, head injuries, but those that suffer nerve injuries, neck injuries, people that have underlying conditions or disorders that play sports, like migraine patients, people with seizures, multiple sclerosis, all sorts of neurological diagnoses. We also manage and discuss the health benefits of sports and exercise, which we'll touch on today, and how neurological system fits into athletic performance. This talk isn't exclusively tailored to athletes, but this is kind of how I like to think about brain health and this topic in general. A lot of these talks are focused primarily on concussion, but the way I like to view it is kind of a circular process where concussion is definitely an important part of it, but more important is how that brain is doing over that athlete's lifespan. We'll touch on each of these points moving forward. But let's start with the one we want to hear about. So definition and diagnosis of whatever this big bad thing is called concussion, right? So in general, we define it as a pathophysiological process affecting the brain due to a mechanical force, which is quite a mouthful. But basically it means it's disruption in the way that the brain functions due to some sort of trauma. Typically, the symptoms associated with concussion are rapid in onset, either immediately after the trauma or shortly afterwards. And for the most part, they are short-lived and they resolve spontaneously. We consider this to be a functional injury, which we'll get into more in a second, with no apparent structural damage, at least with conventional imaging. So CAT scans or MRIs, if anyone out there has had an injury like this, are typically normal. So that doesn't really help us. And in general, after a period of symptomatology, usually within the 24 to 48 hours after the trauma, there's a trajectory of gradual improvement over time as the body naturally heals itself. So this is the most common way that we think concussion can happen, is a direct blow to the head, and we think that the brain tends to shift quickly within the skull, causing this injury that we term concussion. But we don't think that that's the only way. We think that any quick movement of the head or neck may be able to cause a concussion, because due to inertia, you may have quick stops and starts, which may move the brain as well. So for example, I see a fair amount of car accident patients where they didn't necessarily hit their head, but they were jerked forward and backwards, and they are presenting with symptoms of a possible concussion. An easy way to think about this is think about the raw egg in your refrigerator. If you go and get that egg and you shake it around, we can imagine the shell is kind of like your skull and the raw egg inside is like your brain. And if you shake it, it kind of moves a little bit. So the brain is surrounded by fluid, so it's not stationary 100%, and any quick movement could possibly move the brain. We won't get too into physiology, so not to make you guys nervous today, but what happens, or we think happens in concussion based on primarily animal studies that we've done, is that there's changes on the cellular level. So at a microscopic level, with ions shifting inside and outside, those of you that remember high school or college chemistry, we have potassium, we have sodium, and this causes disruption in the way that the neurons or the nerves function. And we think that these changes, again, for the most part, happen pretty quickly after the initial trauma. You can see on the bottom of this graph the timeline. But some of these can lead to a lasting change that can last for several hours or days. The other thing that we have seen in some studies that we have done is that there can be a change in the blood flow to the brain. Now, the brain is very important as far as blood flow is concerned. It consumes about a third of the energy that our body produces, and we think that there's some changes in the blood flow patterns after concussion. Interestingly, some studies have shown increased blood flow, while other studies have shown decreased blood flow. That seems to be depending on the time from the initial trauma. But the bottom line is that when you have an increased energy demand due to the cellular changes and a decreased energy supply due to a lack of blood flow, there seems to be an energy mismatch, and the brain kind of goes haywire, and it creates widespread neuronal dysfunction. We think of concussion, as I mentioned, as a functional injury, and another way to frame this is as a large network. So in the brain, there are billions of nerve cells called neurons, and all of these neurons are connected, and they form networks in our brain that control everything that we do, from autonomic functions or automatic functions like breathing and heart rate and blood pressure regulation, to higher thought or things that make us human, movement, balance, speech. And when these get disrupted, it causes the networks to go haywire. So on the left is a grid of a traffic pattern. Obviously, green means good, so there's no traffic on the left. And on the right is a bad traffic pattern, probably anywhere around Chicago, even now. And that's kind of how we can imagine how the brain is functioning after a concussion. So things are definitely slowed down. The signals aren't getting through as they normally would. There's not necessarily a roadblock, and nothing is severed or permanently changed, but things have definitely changed. The typical symptoms that we associate with concussion more recently have been divided into four main categories: cognitive or mental status, physical, mood, and sleep. But these will seem familiar to those, again, that have ever been assessed for a possible concussion or heard about concussion. The cognitive symptoms, which I feel are fairly important in looking for a brain injury, can include such vague things like foggy thinking or I don't feel right, to trouble with processing, disorientation, meaning not knowing where they are, who they are, what time it is, what day it is, or even loss of consciousness at times, which we'll touch on again in a second. The most common physical symptom after concussion or an assessment of concussion is headache. As you would imagine, your brain, gets quote unquote rattled with these injuries, and your head is going to hurt. But you can also have nausea and vomiting, light sensitivity or photophobia is a common symptom as well, in addition to those other changes that you see. Mood changes is not the most common, but we do see that sometimes after a concussion. It tends to be a later onset of the symptom, but you can definitely see irritability, whether that's from the injury itself or the physical symptoms that they're experiencing, meaning I have a headache all day, of course I'm irritable. But you can also see significant changes like depression or anxiety, especially in people that have those underlying tendencies to begin with. And then we're finding more and more about how important sleep is, not only in concussion, but in general health and neurological health. And you can definitely see changes after concussion, which might include trouble falling asleep or staying asleep, or the opposite, sleeping more than normal. And we'll talk about, again, how to manage sleep after a possible concussion. So we talked about the definition, we talked about some symptoms. It seems kind of straightforward, but why is this a difficult diagnosis to make? Well, the first reason is that this is a largely subjective injury, okay? If we look at this image here, this is an x-ray of the arm. You can clearly see that one of those bones is fractured. That's an objective finding. There's no question that that's what's going on. In concussion, we don't have that objective measure. So again, conventional imaging, like a CAT scan on the left, which is basically an x-ray of the head and the brain, or an MRI on the right, which is a magnet, are normal in concussion. So we don't find anything to help us make that diagnosis. The reason we do those images in assessment of head injuries is to rule out things like this. So that bright white spot inside the head is a hemorrhage or a bleeding. So in any any presentation of a head injury where there's certain signs or symptoms like prolonged loss of consciousness, significant confusion, repetitive vomiting, seizure-like activity, weakness or numbness on one side of the body, it is appropriate to get a CAT scan to rule out something like this. But if you don't have those things, in the majority of the cases, you don't need a scan after a possible concussion. Reason number two, not all brain pathology or injuries cause a clinical effect. So this is an intriguing thought process. So we think about two thresholds of concussion. So, initially you have the impact or force, and everybody's brain probably has what we call an injury threshold. So the injury above which, the force above which an injury is sustained. And we also think people might have a symptom threshold. So it's probably the case that a certain amount of injury causes a certain amount of symptoms in an individual, whereas the same amount of force, the same amount of injury might cause a different amount of symptoms in a different individual. So again, without that objective marker of injury, we're left looking at this from a clinical perspective. Reason number three, not every neurological clinical effect or symptom after an impact is due to concussion. And this is a very important point. There are a lot of symptoms that you can have after head trauma that doesn't necessarily signify that you have an injury to your brain. And unfortunately, what's happened, because concussion or head injury is such a hot topic and there's such a focus on it, is that any symptom after an injury to the head is automatically diagnosed as a brain injury. What we have to realize is that can have lasting implications, not only on how that person is managed, but how that person responds to that information. I don't know about you, but I think I would respond a little bit differently if someone told me I had a headache after I got hit in the head versus my brain was injured. I actually just saw a patient this afternoon where I had this talk, and I had actually a low suspicion for concussion or brain injury, because she only had a headache after she got hit in the head. So what are some symptoms or injuries that we should look for, or consider when we're making a diagnosis of concussion. The most common, as you would imagine, is a neck sprain, or a neck injury. So you get hit in the head, usually your neck moves. Most often it's a muscular issue, so not a spinal cord problem, but certainly we can see that sometimes. And neck injuries don't only affect your neck. They oftentimes lead to headaches called cervicogenic headaches, so definitely something to evaluate. This is what I was mentioning, post-traumatic headache. If headaches are caused by a lot of different reasons. Some people have a tendency, like migraineurs or people that get stress headaches, but definitely trauma can be a trigger for headache. And if headache is the isolated symptom, the only symptom after an injury to the head, I am less inclined to call that a brain injury versus a post-traumatic headache. Nerve pain, again, at the back of the head. A peripheral vestibular injury or disorder causing dizziness. So for those of you that have heard of vertigo or benign paroxysmal positional vertigo, that's an inner ear problem, not a brain problem, and not an uncommon finding with an injury to the head, so that needs to be evaluated for. Anxiety or panic. Sometimes people are in an accident or get hurt and they go into panic mode, and that can definitely manifest as physical symptoms. For athletes, getting the wind knocked out, development of a migraine or dehydration, a jaw injury or temporal mandibular joint, lightheadedness from low blood pressure, not necessarily from a brain injury, any injury to the eye, and changes in sleep or deconditioning. So this is just a short list of possibilities to consider when assessing a head injury or a possible concussion. And then 4, kind of building on that, even if a person is concussed, that doesn't mean all of their symptoms are due to the brain injury. So you can't stop thinking when you see a person for a head injury or possible concussion. So that being said, knowing that we don't have an objective test or marker of the injury, how do we make this diagnosis? And I would wager if you went to 5 different doctors, even maybe those who dealt with concussion, you might get 5 different answers. Hopefully not that different, but a little bit different, and I'll just tell you kind of what I look for. So the first is any underlying diagnoses or tendencies that person might have. Again, is this a frequent headache person? Is this an anxious or depressed person? Is this a person who has sleep problems or normally? And the reason that's important is because if people have underlying symptomatology at baseline, it makes it a little bit harder to assess that in any relation to an injury to the head versus someone that doesn't. It can also portend a longer recovery if you have one of those things. You don't necessarily take longer to recover, but it's a higher likelihood than not. Number 2, the mechanism of the injury. So as humans, we bump our head sometimes. Not every bump to the head is a brain injury. Even forceful bumps to the head aren't always a brain injury. So we don't know exactly the amount of force, but it takes a fair amount of force to cause a brain injury. So that needs to be taken into account. Was there loss of consciousness or amnesia? When I said there weren't any real objective findings or tests for concussion or brain injury, these are 2 that are still considered to be signs of a brain injury. So if someone's knocked unconscious, or they don't remember or are clearly confused and can't answer basic questions, those are typically considered to be hard signs of a brain injury or concussion. Symptoms, so what are they experiencing? Is it consistent with brain injury or one of those other things that we looked at? And when did they start? We do accept that there can be a delay, somewhat of a delay in concussion symptoms, but there has to be a limit to that. You know, typically a week later, we're not seeing the effects of a brain injury, especially if that person has been doing their relatively normal routine. We wouldn't expect that to kind of pop up out of nowhere. And then what have those symptoms done since the injury? Again, we'll go over this in a little bit, but they usually peak pretty quickly and then gradually improve. And then looking at any other injuries that are going on. So that's what we use to classify any assessment of head injury into a level of diagnostic certainty for concussion. Again, understanding that this is definitely a gray area and not a black and white diagnosis. And that's the way I look at it is definite, probable, and possible. And this is adapted from some other sports neurologists that put this together. again, we look at all those things we talked about to put them in this category. And what we typically do is end up treating definite and probable concussions as concussed. So again, understanding that we can never be 100% sure that there's no concussion. We always err on the side of caution, especially with young people and people that are getting back to activities, putting them at further risk for head trauma. But with possible concussions or very low suspicion, you can look at that on a situational basis. So you might be a little bit more liberal with some people versus others if you really aren't convinced that there's a brain injury. Again, with the understanding that we're never going to put anybody at risk, or I'm never going to put anybody at risk, even if there's a possibility of a brain injury. So how do we manage these? So this is, I'm not an artist or a PowerPoint expert, so bear with me, but this is a crude graph of how we view the injury of concussion. Obviously on the y-axis is injury, on the x-axis is time. If we imagine at the origin that that was the impact itself, again, we think that the injury peaks pretty quickly. The injury itself about 24 to 48 hours after the impact. And then gradually over time, in the absence of further trauma, the brain heals itself. For the most part, the dotted line, the symptoms follow a similar trajectory. As you would imagine, when the injury is the worst, you feel your worst, and then as the injury recovers, you start to feel better. But what we see in actuality, and we accept as normal, is the symptom recovery looks a little bit more like this, where you're kind of fluctuating around a general gradual improvement, but you might have increase or decrease in symptoms depending on what your brain is exposed to. So again, anybody who's heard about this injury or experienced one, extensive cognitive activity might make your symptoms worse for students. Excessive screen use, physical activity, driving in a car. But the important thing to understand here is that we don't think that that represents worsening of the injury itself, just the symptoms of concussion. So those things are important to distinguish. The only thing that could potentially make the injury worse is further trauma. The general recovery process, we divide into three kind of main phases. Acute rest is a brief period, which we've really kind of shortened even more in the past couple of years, 24 to 48 hours, and only for those people who really need it, who are really, really symptomatic, where you're kind of just hanging around. You're not doing much. You're not doing much schoolwork. You're not going to work if if you're not feeling well. You're not doing your sport, and you're just kind of resting. But if you don't need that stuff, you don't have to use it necessarily. We get people into the second stage called relative rest fairly quickly. So you're getting back to your normal routine. You're in a return to learn or return to work program, depending on your age or what you're doing. You're up and about. Parents love this. Kids can start to do chores and see how that feels. Importantly, and again, something that's changed more recently, for students, we're getting you back to school as soon as we can and as soon as you're comfortable while managing your symptoms, because the longer that the students are out, the worse they tend to do. They worry about missing school, they fall behind. When they walk into school, then they're very symptomatic. And we've found if we get them back earlier, they tend to do better. And then lastly, for those athletes, or even as a recovery tool for concussion, we start physical activity. And we'll talk a little bit more about this in the context of return to play. How do we manage these injuries? So a timely evaluation is important. I want to see these patients as soon as possible so I can get the story and understand their symptomatology from the beginning. And I can also make any necessary referrals. And I can assess and treat for any concurrent injuries. So what am I doing at my initial visit? I'm obviously getting as detailed as detailed review of the event as I can and the timeline since the injury. I'm evaluating again any past medical history or past medical symptomatology to see if that's playing a role in their presentation. I'm obviously doing a neurological examination, primarily to rule out any other things I might be worried about, but you can find some things on the exam in relation to concussion. Things we're looking for: general mental status, how that person is communicating with me, a detailed physical neurological exam, and as I mentioned, neck injury is common with these injuries, so I'm looking at the neck. I'll obviously review any testing that's been done, primarily imaging from the emergency room, which again is by and large normal unless we're dealing with something more than concussion or possible concussion. And then importantly, a comprehensive management plan, which involves education about the injury and expectations for recovery. Unfortunately, there is no treatment specifically for the injury of concussion. We don't have that technology yet. So treatment is symptom-based. And we somewhat treat symptoms as we would if they were due to any reason. So headaches we treat as we would a headache for any other reason. Sleep disorders, similar thing. I feel that early treatment of headache is appropriate and often leads to a better outcome. I'll start with conservative management, including lifestyle factors, hydration, good sleep patterns, good diet, over-the-counter medications, and then escalate treatment if needed. As I mentioned, sleep is very important. And what often happens in concussions is people are told to rest, and sleep, which we'll talk about again in a second. Whereas that can be actually detrimental because you start to change your normal sleep pattern and your sleep isn't of quality, it's just of quantity. So we actually want quality of sleep. Any mood problems we want to get on top of early because that can definitely affect other symptoms. Cognitive symptoms, I don't really treat initially. We will provide academic accommodations or work accommodations if we need them, and then consider further testing if we need to. And then any vestibular ocular symptoms, dizziness, trouble with eye movements and balance, or cervical or neck problems, we'll send to physical therapy in the appropriate timeline. And then any other specialties that are needed, ophthalmology if there's a possible eye injury, orthopedics if there's a concern for other injuries, as could be the case in car accidents or slips and falls, or psychology or mental health. And then if there's other things going on, again, primarily outside of concussion or in addition, then I might order some imaging. If there's a nerve issue, an EMG, which is a nerve test, neuropsychological testing for prolonged cognitive symptoms, and for workers, a functional work assessment if needed. Okay, so kind of jump into athletes for a second. Whenever a concussion is suspected, we immediately remove that athlete from play. And that is because, again, the biggest risk for worsening of injury is sustaining further head trauma. In addition, they've looked at studies in athletes that have had possible concussions or were subsequently diagnosed with concussion, and outside of any further impact, even continued play without further trauma can lead to prolonged recovery. And again, the thought behind that is that when you're having that energy crisis, you don't want to take away that energy by continuing to play. So immediate removal is recommended. This does not mean you're making a diagnosis on the sidelines. The only decision is to make a go or no go. So should they go back in or should they be out? Again, with any concern for concussion, they should not go in and they should be referred and evaluated as soon as possible. And as I mentioned, early removal or immediate removal leads to faster recovery. So that's good for the athletes to know. The sooner you come out, the faster you're going to get back. And again, we want an expedited referral so we can figure out exactly what's going on. So how do we manage acute sports concussion? So again, anticipatory guidance. What do we think is the diagnosis and what does the recovery look like? The number one question, when do I get back on the field? And we definitely have to temper that at times, but it's never, it's not always, oh, you're going to be back in 3 months, which they're worried about. We get on top of their symptoms. We assess any pre-existing conditions. We discuss activity level and the return to play. Again, early mental and physical activity is safe and beneficial when done properly. So we're not getting them right back on the field in a game, and that needs to be understood, but we can get them jogging or walking or on a bike or something to get them moving again, because these athletes and even non-athletes, they need physical activity, and it's been shown to be helpful for recovery. And then usually down the line, we do some more education and address any concerns, long-term concerns about brain health, especially in contact sport athletes. So these are the phases kind of superimposed on the injury graph. As you can see, the phase 1, acute rest, is usually when the symptoms and the injury are thought to be the worst. Then pretty quickly we get to relative rest, and then what we call graduated exertion or return to play. And this is another graph just explaining that a little bit more. So what is graduated exertion? So that is a series of physical exertion, quote unquote, challenges to see how that patient or athlete's brain responds. And again, going back to the theme of we don't have an objective marker of the injury, the thought is that if we stress the brain and body enough and that person is still injured and on this curve, their symptoms will return because, again, the brain doesn't want that energy to be taken away from it. It's trying to recover. So we put them through non-contact activities of escalating complexity and intensity to see how they respond. And that's one of the major markers of getting them back to full participation. So no athlete goes back to full play until they're 100% symptom-free, tolerating everything that we can give them from an athletic and cognitive standpoint. Of course, and you might think this as well, the sports aspect of concussion for young people gets the focus, but obviously school is the most important. So they're never back to full contact or full sports again if they're not back to full school. That doesn't mean we can't do them at the same time though. And again, we don't want to completely remove them from sport because you can end up with a whole bunch of other issues, including mood issues and sleep issues and all of that. I think it helps with recovery if they can do a little bit of activity. So general categories, cardiovascular conditioning, start with, again, light cardiovascular activity with not a lot of movement. Then you add agility drills, complex movement, depending on what kind of sport they're involved in. Weight training can begin at this stage. Then individual sport drills begin. So soccer looks different than hockey, different than football. And then when we're in a contact sport, then we add contact, always first in a controlled setting, and ideally what we call staged contact or contact that that person is initiating. These are done approximately 24 hours apart, or at least 24 hours apart, I should say. If people develop symptoms at any stage, then they just stay at that stage until they're ready to move on to the next. Sports specifically, again, we consider the specific sport and position. We have to know their usual training. You know, if I'm going to take there's difference between a conditioning of a cross-country athlete and even a football player or a volleyball player. So if I go out and run a volleyball player for a mile and a cross-country athlete for a mile, it's going to look different even if there wasn't a concussion or head injury. So we have to take that into consideration. Again, contact in a controlled setting, athlete initiated, and observed ideally with an athletic trainer or coach. This is just an example of a sport-specific activity. It looks like this is soccer, as we can see in the middle, and again, a graduated process, adding things as tolerated. So some of you might be surprised at this approach because it goes against everything you learned about head injuries and concussion when you were told to rest, rest, rest. And I'm telling you, no, we're going to be active. So how did this happen? And we'll kind of go through this quickly because I want to make sure we have questions, and I can be a little verbose at times. But so where were we, 20, 25 years ago? No idea, no acknowledgement of these injuries at all. Again, this is a situation where the coach would hold up two fingers to the football player and say, you're fine, and go back in the next play. So we weren't doing anything. Then we started to take a look at it. This is the kind of landmark study, and we looked at this graph before in 2001 by Dr. Giza out of UCLA, looking at the pathophysiology of the injury, what's happening at the cellular level. And they said, oh, wait a second, we see these changes, we need to pay attention to this, and it can last several days to weeks. They started doing conferences, and they recommended, probably primarily based on that and the concern around concussion, that we need to completely shut these down. So shut these patients down. Athletes need to be completely asymptomatic and have normal evaluations before the start of the rehab program. And of course, this is when we started to see the football players in the news. Okay, so 2002, everything kind of came to a head. So what did? We completely swung the pendulum the other way and became super conservative regarding these injuries. Rest, 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 dark room, okay, not coming out, no school, no friends, no phone. Then we kind of continue to this, and I'll kind of fly through this a little bit, not that important. But what we started to see was that we were essentially putting our patients in solitary confinement. So any of you that are familiar with maybe prison movies or shows, Oz was an old one that I used to watch. If they're bad, they put them in solitary confinement. And we know that obviously that's detrimental to people because you're removing all normal stimulation. And you can imagine even more detrimental probably to a teenager, where you take away their phone, they can't go to school, they can't play sports, they can't talk to their friends for weeks at a time. And we were actually seeing that these kids were having these patients were having very long recoveries for something that we didn't think should take that long, and developing symptoms that we didn't necessarily think were related directly to the injury, but what we were recommending. And what is post-concussion syndrome? So again, we're back to our graph. This one's a little snazzier. I borrowed it. We think that, again, the injury recovers pretty quickly based on that physiology study. But some people develop what's called post-concussion syndrome, where these symptoms kind of take off from a normal expected recovery trajectory, where we don't necessarily believe, and there's some debate about this, that the brain is still injured necessarily, but that for whatever reason, that person is still experiencing symptoms. So again, injury and symptoms are related, but not always one-to-one. And what we see is that this typically is multifactorial. It's usually not just one thing. It's not, I was concussed and I still have kind of a headache. It's, I have all of those things that we talked about. And in the middle, you see something called Unplugged Syndrome. So again, that's us putting them in a room with no devices and no stimuli. And what we see is that individually, those things are usually able to be managed, but when you put them all together, it becomes this beast we call post-concussion syndrome. And how do we address this? This becomes even more comprehensive, okay? So you need to really spend time to dissect exactly what's going on and address each thing individually, or you are not going to make much progress, okay? So take a history and make a list. So we're looking at everything that's bothering this person, any underlying tendencies, any contributors, again, removal from sport, removal from school, removal from friends, anything that can be contributing, and coming up with a comprehensive approach. Here's just an example of some plans and some timelines that I've dealt with in the past. You can see ups and downs, kind of pretty far out from the injury, a lot of ups and downs that requires kind of a dissection. Okay. So what do we do when we figure this out, or we thought we figured this out? Well, Dr. Letty up in Buffalo, New York, who's kind of a spearhead of active recovery, started doing studies on post-concussion syndrome patients, or prolonged recoveries, probably because it seemed to be safer at that time, and not going against what the norm was. And he found, surprisingly, controlled exercise and cardiovascular activity improves post-concussion syndrome symptoms compared with no treatment. So he found a benefit to exercise. Then they started doing more studies. They found that negative perception surrounding concussion, stress, anxiety, depression, or all or nothing behavior, either 100% out or 100% in, was associated with a risk of post-concussion syndrome. Then they started to question this at the consensus statement in 2012. We didn't exactly see evidence of rest. And they started to say, hey, let's get moving a little bit quicker. So then we moved to an as tolerated approach. So we get them moving when they're ready. And then again, we won't go through this in detail. But then Dr. Letty started pushing the envelope. And most recently, he did a study looking at acute concussion in 2019, last year, and put groups in a sub-symptom threshold exercise group or a placebo stretching group, so essentially no exercise. Athletes 13 to 18 years old within 10 days, so acute concussion, again, even within the realm of still being injured based on that graph. And not surprisingly, he found that the people in the exercise group recovered in a significant statistically significant fashion faster than people that were in the stretching group. So he demonstrated that early physical activity, again, not sport participation, but physical cardiovascular activity, is not only safe, but helpful for recovery of concussion. So now we are in this active recovery space. Okay. So that was concussion, post-concussion syndrome. What else do I look at when I'm assessing an athlete or anyone that comes with concerns of neurological health? And I know we're approaching 45 minutes. What are important questions? Again, how is that brain going into the injury? What do those baseline symptoms look like? Are we missing something? How does that brain recover from an injury? Is this a person that recovers in a couple of weeks every time? Maybe they've had multiple, or are they several months every time? And that's relevant to their quality of life. Did they develop any chronic symptoms after head injury, or are they experiencing symptoms during routine sport or contact participation? And are there any concerns for long-term brain health? So this is where kind of the concept of baseline or yearly evaluation comes in. Just like the athletes go to their primary care to listen to the heart and lungs for a physical, in my opinion, we should be having yearly neurological checkups for people that are participating in sports, specifically contact sports, or most importantly, contact sports. When we're doing a baseline test or a baseline evaluation, a very important question to ask is where a potential injury will be evaluated, because that's the person that will determine what information is most important. And will be most useful to the doctor who will be evaluating. Ideally, again, we do have various computer tests and things we do for baseline testing, but in my opinion, again, this should involve a detailed neurological history and examination. I can't tell you the number of times that I'm diagnosing stress-related headaches, migraine headaches, insomnia or sleep disorders, mood problems, in kids that come to me for either concussion evaluation or baseline that have never been asked about these things, and that we can address those. And again, those can be risk factors for not only issues in normal life, but certainly after a possible brain injury or brain injury. And as I mentioned, no single test is used for diagnosing a concussion or determining return to play. So that's a clinical decision. So on the left is what we use, an example of what we use for a concussion evaluation. So this is just a list of symptoms, okay? I don't really like that word, but it's what we have. And on there you see all the things that I talked about in the presentation of concussion. You would think that if I gave this to a local high school that all of the kids would put all zeros for these symptoms on a normal day. But again, you would be very surprised. Probably 50 to 60% of them look like this. So my point is that people aren't walking around with no symptoms in normal life. So it's definitely important to know these things when you're going to evaluate them for a possible brain injury. Young people have these issues: anxiety, depression, headaches, vertigo or disorientation, sleep problems, very common. So we need to know about these. Up to 10% of school-age children have migraine headaches. That seems high. Probably more of them have other types of headaches, not classified as migraine. Almost half of all people with migraine have their first episode before 12. Again, that sounds young, but if we don't ask about it, we're not going to know about it. And obviously, it's underdiagnosed. Attention issues, ADHD. We probably know this. The mean age of diagnosis is around 7 years old. 8 to 11% of children are diagnosed with this, and it's fairly common. Mood disorders. So this is a hot topic. This, especially now, given the social situation, but even before, there were escalating numbers of anxiety for a number of years. They did a study, 4 or 5 years ago, looking at incoming freshmen, and it was 30 to 40% of students had symptoms of anxiety. So it's high, it's out there. And we know that anxiety and depression can lead to physical symptoms. For example, on the right is a schematic or a word cloud, maybe, of anxiety symptoms. And on the left are symptoms of concussion, possible concussion. You can see how these match up. So what are we dealing with, right? We have to assess this. So what are we looking at in the baseline? Again, screening for underlying diagnoses, monitor any chronic symptoms or make sure they're optimized, monitor for brain dysfunction or evidence of brain dysfunction, usually for long-standing, contact sport athletes. Assess sports health quotient. So what is the risk versus benefit in participating in sports? Are we playing too many contact sports? Are we playing one sport and we should be playing different sports? Speaking to that, the annual dose of force. So again, maybe 3 seasons of contact sports isn't the best idea. Maybe we should throw in cross country there or something else to get the health benefits, but not necessarily the risk of impact. And any risk of future exposure. Am I talking to a person who's likely to play football through high school, or they have a shot at playing professional football for the next 15 years? That's a different conversation. And of course, this provides an opportunity for education. We won't dive too deep into this, but when do I consider retirement from sports or making a recommendation that they shouldn't play their sport? Number one, this isn't a plug and play. So it's not the same for every person. You have to consider all those things we just talked about. Importantly, baseline diagnoses, again, in symptomatology, the number of sports they're playing, how long they're going to be playing for, any concrete evidence or objective evidence of brain dysfunction, and their general kind of symptomatology. We have to weigh that against the health benefits of sports that we know exist. So we know that young people that are engaged in physical activity or sports are, number one, more likely to be physically active when they're older, which fights against known killers like heart disease, obesity, diabetes. And actually multiple studies, as opposed to what you may have heard, have looked at high school athletes in their later years, high school football athletes, and they've actually found that in addition to those things, they are also less likely to be suffering from psychological or neurocognitive disorders. So there's definitely a health benefit. How do we minimize the risk? So we want to understand that individual. It's not the same for everybody. We don't, while we think that individual concussion recoveries are usually temporary and go away, we don't know the full impact of repetitive head trauma. And probably getting hit over and over in the head again, for 6 or 7 months out of the year isn't good. So we try to temper that overall exposure. That also brings into the fourth point, which is safe techniques. We can't avoid concussions altogether, but we can play safer to minimize the risk. Support infrastructure. So today is actually the safest time in the history of probably time to be playing sports because of all the rules that have been put forth. We've changed practices to limit contact. We've immediately removed from play. We've allowed timeouts to evaluate. So this is the time, the safest time, and I imagine it's only going to get safer. And then I'll leave us with this recent study that just came out, actually, looking at how to prevent dementia, which is kind of losing your faculties when you get older, and kind of live a healthy lifestyle. And they've identified 12 modifiable risk factors that they think account for about 40% of the risk of dementia worldwide. And some of these probably aren't a surprise to you. So these are kind of lifestyle factors that we can do to prevent modifiable risks of dementia. Now, some of it is genetic, so you can't avoid that, but you can minimize it. So diabetes, definitely a risk factor, high blood pressure, smoking, obesity, midlife specifically, frequent exercise, so those are things to avoid. Things to do, frequent exercise, treat depression, avoid excessive alcohol, pretty self-explanatory, and then maintaining frequent social contact. So we know that people that are concerned about cognitive insufficiencies when they get older, definitely we recommend that they remain socially engaged. And just like I said, a lot of these things are treated or addressed with healthy living and regular physical activity. They did put prevent head injury on here, so that is thought to be a possible risk factor for developing neurocognitive issues when you're older. Again, we don't know the extent of that or how exactly it plays a role, but as I mentioned, probably getting hit in the head over and over again can't be good for your brain. So that's what we try to avoid, and we evaluate any head injury or possible concussion on an individual basis. And then they kind of put this into a schematic of when you might experience these things, and they gave a percentage of 3%. Again, this is an estimate, not exactly, of traumatic brain injury possibly being involved in those modifiable risk factors. But again, you can see hearing loss, 8%. That's more than double of traumatic brain injury. High blood pressure, 2%. Alcohol and obesity, 2%. Less education, 7%. Smoking, 5%. So, you know, while traumatic brain injury or head injury is involved in that, there's other things that are much more easy to address and avoid in order to kind of live a healthier lifestyle and avoid those neurocognitive concerns when we get older. So that's kind of what I wanted to talk about. Again, I framed it in an athlete evaluation or assessment. Obviously, concussions can happen to anyone. I see a large population of car accidents, slips, and falls. I will caution, again, any parents or kids out there, bike accidents, scooter accidents, skateboard accidents, which seems to be becoming popular again. We should be wearing helmets. Helmets don't necessarily prevent concussion, but they do prevent serious traumatic injuries like intracranial bleeding and things like that. I did see in office last week, 3 out of 4 of my pediatric patients, either off of a scooter or a skateboard, had head injuries with intracranial bleeding, subdural and subarachnoid hemorrhages, which are serious injuries. So it's not just sports, and definitely not a scare tactic, but we need to be safe out there while we're kind of filling the time when we're not involved in sports. I look at the athlete and brains from an overarching perspective, not just focus on concussion, because we want to make sure that, again, patients and athletes are doing good throughout their life, not just while they're participating in sports. And that's all I have for you. Thank you very much.
All right, Dr. Savino, thank you very much. It's Karen Brownlee again. I have a list of questions that people have sent in. Thank you to everyone who sent in your questions. And I'll just take them in order, the order that I received them. So the first one would be, can you comment on nutritional components of brain health?
Sure. So I think, as was kind of evidence maybe in that last slide, that a healthy lifestyle is the ideal. Actually, they've been looking at, actually Rush here in Chicago, it has a great cognitive center and dementia center looking at research, and they found that the Mediterranean diet specifically seems to be the target for nutritional benefits in brain health. And that's, you know, as we know, lots of fish, lean meats, vegetables, but also, as we know by Europeans, a lot of walking, a lot of physical activity. So basically, you know, in general, a healthy diet is best. In terms of maybe vitamins and supplements, which might be the other question of the point, by and large, we get a lot of those from our diet, especially, again, if we're eating leafy greens and vegetables and fish. Living in the north, you know, we do sometimes have to supplement vitamin D because we don't get enough sunlight, or other people might have specific vitamin deficiencies because of malabsorption or other underlying medical conditions. But by and large, vitamins and supplements should only be used if that person is found to be deficient or doesn't have another way to kind of get those vitamins in. But outside of that, there's nothing specific necessarily to kind of optimize the brain health.
Okay, great, thank you. Here's another question that came in. Having chronic tinnitus from a boat explosion, should I be concerned as I age with mental acuity?
So you saw on that, so tinnitus, for those of you who don't know, is ringing in the ears. That's the kind of the medical term. And yes, common causes are exposure to loud noise, whether a single incident or more commonly repetitive, like working in a factory or musicians or things like that. And also hearing loss can lead to ringing in the ears as we get older. As you saw in that schematic, again, the last page there, hearing loss is a risk factor for developing dementia. And we don't, I think, understand whether that's because of hearing loss or hearing issues that people become more socially isolated and they don't engage that social contact, whether it actually turns off a part of their brain because they're not hearing correctly or able to communicate correctly, and that leads to kind of more detrimental findings. I don't know that we understand the pathophysiology yet, but definitely even before this study, that was a known hearing loss or hearing issues was definitely a known risk factor for developing neurocognitive issues. Tinnitus specifically is kind of tough because we don't have a specific treatment for it. There's no medicine. You know, the only thing really to address is any hearing loss with hearing aids. And then more recently, they've started to come out with hearing therapy. I don't know the efficacy of that yet, but basically an attempt to kind of retrain the brain to either not experience the symptom or get past it. So I'd say, again, in general, preserving kind of auditory health, hearing health is ideal. And if we have those symptoms, to get it evaluated by an audiologist or an ear, nose, and throat doctor to see how you can optimize that symptom.
Great, thank you. All right, a few more.
Okay.
This person says they had a concussion in November of 2018, stuttering at times when changing direction of conversation. Is there anything to help with this?
So you can definitely have, sorry to hear that that's going on. You can definitely have speech changes or again, language changes after concussion or brain injury. It's not all that uncommon. And sometimes you can have prolonged symptoms of that. The typical evaluation for cognitive or speech symptoms specifically is something like speech therapy or speech cognitive therapy. So that's meeting with a therapist that specifically focuses on the speech patterns and cognitive status. Outside of that, you know, just continuing to engage in your normal speech patterns and conversations and socially is kind of the best you can do. Again, there's no treatment really like a pill or anything magic kind of for the treatment of concussion. It's really just symptom based. If there's concerns for cognitive symptoms as well, like processing issues or attention or memory, then in addition, something like neuropsychological testing can be helpful, which is a battery of tests looking at all aspects of neurocognitive functioning.
Great, thank you. How is chronic traumatic encephalopathy related to concussion? So that's the CTE that people talk about, right?
Yep, that's a great question, and that's a whole nother talk or another day of talks or more. But just to kind of touch on it, I will say first that chronic traumatic encephalopathy, CTE, and for those of you who haven't heard it, it's the thing that, you know, football players are concerned about, and unfortunately some people have taken their lives because of concerns that they're developing it. Remains what's called a neuropathological diagnosis. So we can only diagnose it under a slide after autopsy. So it's not something that we can diagnose in life yet. They are making progress in that regard, but we are not quite there yet. So that's number one. Number two, when all this kind of madness came out or concern for concussion, as I mentioned, kind of the pendulum swinging, it was put forth, and not necessarily by the people that did the studies, but maybe more so by the media, that concussion was directly linked to CTE, meaning if you had a concussion or multiple, you were going to get CTE. Well, we know that's not true. We know a lot of people, you know, the majority of people who have concussions do not have problems when they're older. And what they found after doing more research is that it's it's not thought necessarily to be the individual concussions that that can lead to long-standing changes, but rather repetitive head trauma over time. So the focus has shifted to more avoiding of repetitive trauma and obviously appropriate recognition, evaluation, and management of each individual concussion injury. So that's kind of where we stand as far as the understanding of it. There are still leaps and bounds more to go to understand again, but that's kind of the hypothesis that's been put forth more recently.
Thank you. That's actually a very, very helpful explanation. The next person asked, you said keeping light exercise is good and can help with recovery and helpful to preventing other problems. How do you go about implementing light exercise when you suspect a concussion? And you talked about that a little bit, but I wanted to make sure to cover that person's question.
Sure. Great question. So I think the first part in regard to, or the first thing to mention again in regards to, let's say, athletes, in-season athletes that we're getting back to sport, is that light exercise and cardiovascular rehabilitation does not mean return to play. So that's the first thing that kind of needs to be separated. And that takes some education, because if you give a kid a green light, they might, an inch, they might take a mile, but most of them are happy to get moving in some way. The way I initiate it, and again, I'm looking to get people moving based on, their symptomatology, even 2, 3, 4 days after the trauma, if they can tolerate it. I usually start with something simple, depending on what they have available to them or what I can provide to them in the office or through physical therapy or athletic trainer. The specific mode of activity isn't the most important thing. It's what you're doing with the activity. So people will, you'll hear, oh, you got to ride the bike first, then you got to run first. And, so kind of this progression, which is, again, put forth from previous consensus statements looking at return to play processes. But what's important to me is that I want to know how you're tolerating increase in heart rate, increase in blood pressure, sweating, movement, those sorts of things. So what I usually say is, if you have a stationary bike or treadmill at home, or if it's nice outside and you want to go for a walk or a jog, then that's what I would recommend. I would usually start at kind of 25% maximum output. So something that's very basic for an athlete, something that they would be like, God, this is easy. I don't even want to think about this, but they haven't done anything yet. And then 15, 20 minutes. And then what we do is we assess their initial tolerance to that activity, and the two kind of ways to go. If they tolerate it with no significant worsenings of symptoms or no symptoms, then we progress them to more intense activity and longer activity. If they develop significant symptoms and have to stop, then obviously we stop that activity and we try that again the next day and move on when they're able to tolerate that. And then we stay in that cardiovascular realm until they're essentially kind of symptom free. And then again, for athletes, we move them on to the sport-specific activities. For non-athletes or older athletes who aren't in sport necessarily, we just get them back, we increase their cardio tolerance.
Great, thank you. That makes a lot of sense. All right, we have a number of questions from an athletic trainer named Faith. And Faith says, I have always been told that if you see a significant blow to the head during a game or competition, to take the athlete out of the game immediately with no chance of re-entering. Do you still believe this is the right plan of action, or should we wait to see if the patient reports any concussion-like symptoms?
So I would say that that's never the wrong action. And especially for athletic trainers who are usually outnumbered and under the gun and have a lot of things going on, the last thing they need to be worried about is thinking, does this person have a brain injury or not? So first and foremost, when in doubt, sit them out. I'm definitely a proponent of that. And I think the point that she's getting at, and I kind of touched on but didn't go into fully, is that you can have delay in symptoms. So, the athlete might feel fine and look fine and not develop symptoms for 2 hours later, whereas you might have put them back in and gotten them, had another impact. So I am definitely a proponent of any significant blow or any concern for an impact that causes concussion for that athlete to be removed. And, that sometimes leads to heartache and tears and all sorts of parents being mad, but it's really not worth it. If there's someone there, I will say, if there's someone there physician-wise or neurologist-wise, that can do an assessment and can make additional recommendations, then that's fine. But I would say at the trainer level and most certainly at the youth and high school levels, we should be taking no risks, and they should be removed and removed and monitored for any development of symptoms and referred for any concern for concussion.
Great, thank you. And then she goes on to ask, also, should we still consider the SCAT-5 as the bare minimum gold standard for athletes prior to participating in their sport?
That's another great question. And I will say, Faith, that thanks for asking. In my mind, as a neurologist, ideally, every athlete would come see someone like me and have a conversation and talk about their brain health and do an exam. But that's not going to happen, right? Because we have too many athletes and not enough physicians. And so we do what we can. The SCAT-5, for those of you that don't know, is a tool that's now been through 4 iterations. It is SCAT-5, but there's only been 4 actually, that looks at various things that we might see with a brain injury. Again, that symptom list is on there, but in addition, there's orientation questions like, where are we? What's the date? What day is it? Balance assessment, neck assessment. So it's a more comprehensive evaluation. And it's really at this point, the go-to sideline tool to use for assessment because they found that it's good at ruling in concussion. So people that kind of score poorly on that tend to be diagnosed with concussion. Again, the only thing, so I think it's a good tool, and it's definitely better than nothing to be used when we can. The one thing I will say again is that I think it's most helpful if we understand a person's symptomatology before we use that to assess a possible head injury. And again, resources can be thin. We can't ask every kid how many symptoms they have every day, but that would be, helpful information that we could use in assessing a possible injury to know that, yeah, they get headaches every day or every time they play football. This isn't abnormal for them. But we use the resources we have. I think SCAT-5 is a great tool. It's not the only thing. It's not the end-all be-all answer again, but it's something that can definitely be helpful in assessment of a possible head injury.
Great, thank you. And then she says, last question, I promise. After you rule out a subdural epidural hematoma / any other emergency brain conditions after a concussive mechanism of injury, do you still prefer Tylenol over Advil or aspirin or other NSAIDs?
NSAIDs, yeah. These are great questions, Faith. So we do tend to recommend, and she made an important point, you rule out other bleeding injuries because NSAIDs like ibuprofen, Advil, naproxen have a little bit of a higher risk of bleeding than Tylenol. For example, we use Tylenol in people that have bleeding in the head, so it's definitely safe. Despite that, we do tend to recommend the use of Tylenol within the first 24 hours or so after an injury to the head. That's primarily, or concern for concussion, and that's primarily in people that don't have a scan. So if we have a scan that's negative, I think I'd be more comfortable with using an NSAID. But certainly in people that don't have a scan and we're not 100% sure, I still recommend using Tylenol within the first 24 hours. And then after that, I would move on to using whatever medication that they're most comfortable with or that they most respond to.
Great, thank you. And Faith, yes, thank you for the great questions. They were really, that's why I kept them in order. So now we'll go to back to some lay people questions.
Okay.
So how frequently and under what conditions do you refer for neuropsych evaluation?
Good question. So neuropsychological evaluation, again, is that battery of tests that looks at all aspects of neurocognitive functioning, like memory, executive functioning, planning, attention, processing. It's performed by a neuropsychologist, which is a psychologist with specific training and assessment, performance and assessment of those tests. I would say it's fairly rare for me to refer someone to neuropsychological testing, especially in the youth age group. I tend to do it more so in the older age group, where I find cognitive symptoms to last a little bit longer than in the younger age group, even when other symptoms have resolved, which isn't surprising because, unfortunately I have to say this, as we get older, we have less cognitive reserve. Our brain actually shrinks as we get older, and we have less ability to deal with injuries, especially injuries to the brain. So if there are any persisting symptoms, cognitive symptoms, I usually say beyond 2 or 3 months, then I refer someone to neuropsychological testing. If a youth patient or athlete is having increased trouble at school, they've developed what appears to be an attention problem, or there's just, they have persisting cognitive symptoms, even when their sleep is normal or fixed, back to normal, their head pain is normal, everything else is normal without any other contributing factors to cognitive symptoms, because we know poor sleep can lead to, I can't pay attention. When I'm depressed, you can have cognitive symptoms. When you're in constant pain, then I'll refer them for neuropsychological testing. Or if we're looking for any formal or long-standing academic accommodations, then it's very helpful to have the support of a neuropsychologist.
Great, thank you. That all makes sense.
Mm-hmm.
Someone else asks, what are your thoughts on hyperbaric oxygen therapy?
These are good questions, loaded questions. So I will say that definitely in our area, hyperbaric oxygen is a hot topic. I will say that there are a lot of studies out there in support of hyperbaric oxygen therapy for a lot of different conditions, and they seem to be helpful. It is used much more liberally in other countries than it is here, and that's where a lot of the studies have been done. In terms of concussions and traumatic brain injury, a lot of the research until recently was done in the more moderate to severe traumatic brain injury space. So, people that are having bleeding in the head or significant, again, neurocognitive issues. And they were kind of mixed results, depending on the treatment protocol, meaning number of sessions, number of time in the chamber. And just by the way, hyperbaric oxygen is like a tank that you'd go in, like if you go scuba diving and you have the bends, you'd go in there. So you get oxygen in a tank, pressurized. So more recently, they're looking at mild traumatic brain injury. And again, the studies kind of seem to be on both sides. Some show a good benefit and some don't show much benefit, depending on the study protocol, I would say. So that's kind of what we know from the literature. I know that local physicians are trying to do a lot of good research here and are definitely proponents of that. In my clinical experience, I would say that I do have patients that have had good results from treatment. It does tend to be more helpful when it's initiated sooner and for multiple sessions. And it seems to be most helpful in my experience with head pain. And kind of physical symptoms rather than the other symptoms, maybe some visual symptoms. So I have had some patients with results. Alternatively, I've had some patients that have not found benefit. And again, I don't think all those patients are the same, because some people go on day 1, some people go on day 8, some go for 2 sessions, some go for 10 sessions. So I think it really, ultimately, if it was to be effective, the protocol matters. The important thing is that by and large, it's safe. So unless you have an underlying lung problem or any contraindication to going into it, like a sinus infection or something like that you can't handle the pressure, it seems to be a safe treatment. So therefore, my recommendation is, or my statement is usually, I don't have the hard evidence to fully recommend it or refer everybody I see for this. However, I find it to be safe, and I have had patients that have found benefit from it. So if it's, a safe treatment and it's conservative, it's not taking a medicine, and you can afford to do it, then go, I'm definitely in favor of it. So that's kind of the way I approach that.
Great, thank you. That's very interesting to me. Good to know.
Yeah.
Here's another good question. Where can one get a professional fit for a good active sports helmet, like a bike helmet or a kid's sports helmet?
Wow, I've never had that question. I don't know. I'm not going to be very helpful here. I don't know of any specific place. You might have just given me a business idea, but I would imagine that any legitimate or long-standing sports store or helmet store would have people that would be able to fit the helmet. What you're looking for basically, and I'm definitely not a helmet manufacturer or anything like that, but you want it to be snug but not too tight, because that can give you head pain or feel uncomfortable. And most importantly, when something happens, not fall off, right? So you don't want, if you're a skier, you don't want your helmet to fall off when you fall. You want it to be on there to protect your head. Depending on the activity, there are helmets that tend to collapse or kind of explode when they get hit, and that's kind of the intention of it, because it absorbs the force. But by and large, for the standard sport helmets, it's most important is kind of the fit and the comfort with the helmet.
Great, thank you. Good. Okay.
Yeah.
We've got just a couple more. Recently,
Okay.
I have begun to fall for no good reason and no definite HX. I don't know what HX stands for. Of head injury.
History.
Maybe diagnosis.
Yep. History.
History. Thank you. Okay. Of head injury. Yep. I have gone to physical therapy without much help. Is that something to see you about? I have done physical therapy. Did that make sense?
Well, that sounds like a specific question.
Yeah, it does.
But,
yeah, and I didn't realize that.
Yeah, I mean, it's hard to diagnose that over the computer, obviously. But frequent falls is definitely something to be evaluated, especially if there's no answer. If you don't have, just because you don't have a head injury in the past doesn't mean you can't have another reason to have falls. So I would say, yes, someone should take a look at that, and if that person is a neurologist or me, then that would be fine.
Okay, great, thank you. And you had mentioned in one of your slides when someone has long-term concerns for brain health, and I was wondering what would cause you to be concerned about someone's long-term brain health?
From my perspective or their perspective?
From your perspective, when you're concerned about someone's long-term brain health, is it someone who's had multiple brain injuries? Is it someone who's, what would cause you concern for someone's long-term brain health?
Good question. So again, I think it's on an individual basis, and it takes kind of going through that history to make that decision. And again, for athletes or non-athletes, and again, I keep saying that word, people definitely have head trauma without being an athlete. You're right, looking at incidences of possible concussions, recoveries from those injuries, what they're participating in now, and what is bothering them. So, back to that injury threshold, there's certainly people that probably have gotten hit in the head very hard, might even have some injury that doesn't become apparent in the clinical sense. They don't have symptoms of it, versus someone else might hit their head on a cabinet and have headache for 2 weeks. So there's definitely a difference there. And that needs to be taken into consideration when you're talking about brain health or talking to an athlete and deciding or making recommendations in participation of sports and contact sports. So it needs to be individualized. So that's kind of how I look at it, and I focus on those questions. So what is that person's baseline level of symptoms? Are they walking around with frequent headaches? Are they depressed? Do they have depressive episodes? Do they have trouble at school? And are those things, managed or optimized, or are they just kind of out there? History of head injury and recovery, as we mentioned. I'm gonna assess someone differently if they've had 3 possible concussions, but they've recovered fully in 1 week from each of them and they don't have any chronic symptoms, versus someone who's had one concussion and they've taken 6 months to recover with symptoms. So that's, that's different, even though they've had different number of injuries. And then again, exposure to impacts. Am I talking to a high school athlete who's going to be done when they enter college and they play 1 season of contact sports a year, versus a triple contact sport athlete, one of which might go on to college or beyond? So that's a different conversation. And it's not that means I'm going to tell them that they can't play sports or that their brain is going to be injured permanently, but it's something that needs to be monitored, because again, in the absence of any objective marker, we don't have a blood test to follow. There's a lot of news out there recently, but we don't have it yet. There's no imaging study. There's no brain test to follow. The best way to follow these people is clinically, and meeting with them on a regular basis to understand if and what their problem is and what that might be from. If it's from contact sports, head injuries, then that needs to be addressed. If it's from other issues, then it needs to be addressed, from that perspective.
Great, thank you very much. That was really helpful.
Mm-hmm.
And we had Anita responded and said, Advocate Children's Hospital Pediatric Trauma Department has a resource center at the Yachman Pavilion that sells bike helmets and assists with proper fit. So thank you, Anita, for that. And then lastly, we have someone that says, not a question, I want to say thank you. I'm a school nurse in a very rural setting, and this was very informative. So, and I think
great, that's great.
Us on this call would agree.
Great.
So thank you very much.
It was my pleasure.
For all the
Thank you
questions that came in.
Okay.
And I just want to make sure I covered all of them, but I think I did. So thank you so much. Thank you to the IBJI team. It's great working with all of you on behalf of the YMCA and everyone in attendance tonight. Thank you so much for all of your effort in putting together such a great program for us.
Thank you very much. It was my pleasure.